I've headed this presentation up health workforce policies in the pandemic. And the idea really was to look at some of the approaches around workforce and how workforce planning is done across the four nations. So I'm not going to focus too much in terms of the pandemic, because I know Julie's speaking about specific pandemic responses as part of her presentation. Also, some of the context in terms of what I'm going to talk about would have been covered by my colleague, Professor Jim Buchan from Queen's University in Edinburgh, who unfortunately can't be with us this morning, but would have talked around about comparisons of workforce planning and workforce approaches across the UK, and comparing it to some of the metrics that we see from Europe. So, Ellie, next slide. So I'm going to spend the next 20, 25 minutes initially talking about metrics and how the UK compares with some of our OECD counterparts, particularly in terms of bed numbers, training. I'm going to focus mainly on the figures for nursing and midwifery, primarily because they tend to be the largest workforce across the various nations, the OECD nations. So I think it's probably more useful to look at that. It gives a flavour in terms of how other nations are actually approaching their workforces and their workforce planning. Briefly mention some of the approaches that have been taken in terms of COVID-19 across the workforce and across the four nations. Very high level, because I think Julie will get into more specific detail around that. Maybe talk a little bit about some of the governance and policy issues. My perspective from working in the Scottish Government. I think it would be interesting to hear maybe during the chat later on, or if you have any questions about your thoughts in terms of your own particular country and the response and the approach to workforce planning that's been taking place. Going to, at the end of that, give a brief overview of workforce planning in Scotland, some of the detail around about what we've been doing in terms of developing workforce planning across the last 3 to 4 years, and clearly everybody's approach to workforce planning has been significantly affected by the pandemic. So I think it would be useful to show you what our thoughts are in terms of moving forward and developing workforce planning as a particular function. So that's broadly what I'm going to speak about. Next slide, Ellen. A quote from an OECD publication here to start us off. So you'll see there it says, the first wave of the COVID-19 pandemic made pre-existing shortages of doctors and nurses much more visible and acute in many countries. And I think that's clearly the situation that we have observed within the United Kingdom as a whole and individual nations. Prior to the pandemic, a lot of discussion about vacancy levels, shortages across a number of particular specialties, nursing being the main one, but obviously sort of medical specialties as well. And before the pandemic, that simply was almost a workforce planning situation that we were looking to resolve. We were looking to try and fill the vacancies. OECD and workforce planning reports, our previous World Health Organization report on workforce planning and the need for workforce planning in 2015 actually gave a number of reasons why we should workforce plan. The first one that was highlighted was the economic benefits, the kind of multiplier benefits of actually employing people within health and social care service. It's very positive. It engages the workforce. There's a high proportion of female workforce within health and care services. So it creates relatively well-paying jobs for both the female workforce and also young people. But one of the other areas that it talked about in particular was it allows preparation. It prepares us for unexpected events. And of course, I think we can all agree that the pandemic was an unexpected event that actually occurred and placed a great deal of pressure in terms of health services across the globe. Now, as you see there, it indicates that some countries, particularly Norway, Switzerland, Germany especially, in the early stages of the pandemic, were highlighted as having a sort of a relatively high number of doctors and nurses per capita. And this allowed them to respond better. The perceptions that these countries responded better or were better placed to respond to the immediate or initial pandemic need and the steep rise in terms of demand for care. Ellie, the next slide, please. So this is the start of a few slides where we're looking at metrics. This one in particular is OECD health expenditure per capita for the year around about 2019, so just before the pandemic. You see the dark blue line there talks about government and compulsory spending on healthcare. The lighter blue lines more around about voluntary out-of-pocket private healthcare expenditure. So unsurprisingly, and the figures are given in US dollars, the nation that spends the most in terms of healthcare is the United States. So they're up around about 11,500 US dollars per person spent on healthcare. So healthcare is huge. A huge industry within the United States, not necessarily a good thing in terms of people's access or immediate access to healthcare. But you'll see some of the other countries that we've just previously mentioned there, Switzerland, Norway, Germany, fairly high, much higher expenditure in terms of healthcare than other nations. The arrow that points down there, the blue arrow that points down, highlights the figure for the UK. So across the UK, the average spend per capita on healthcare is around about 4,500 US dollars. So probably, I don't know what that is in terms of the current exchange rate, probably around about £3,000. Now that varies across the four nations in the UK due to Barnett formulas and Barnett consequentials, and spending in Scotland is slightly higher per capita than England. But what you see there is that United Kingdom, in terms of the red line there, the red bar there being the OECD 38 countries average, the UK is actually spending per capita slightly more than average in terms of health expenditure. Next slide, Ellie, please. Okay, so this is a figure for hospital beds and the change. It might be useful to have a look at what the changes are between 2009 and 2019, so over a decade period. So the country that highlights with the highest per thousand population number of hospital beds is Japan, and the figure hasn't significantly changed, or actually it's gone slightly down in the last 10 years. The figure there for Korea, significant increase in terms of the number of acute hospital beds there, and the figure drops. But we note there the kind of Russia and particularly Germany. Generally, we've highlighted this as a country that had a high number of hospital beds at the start of the pandemic, so was able to actually cope with a sudden rush in terms of demand for actually hospital beds. If we go down to the blue arrow and drop, see there that actually the figure for the United Kingdom is significantly less in hospital beds per capita, and has slightly reduced over the last 10 years. Now, this may well be kind of almost the impact of deliberate policies across the four nations of the UK to actually increase the amount of care that's provided within the community, try and reduce the acute hospital estate across the four nations, because of course we know that prevention is better than cure, and acute hospital care is much more expensive than actually providing care in the community and looking at preventative measures, trying to base it around that. So at the moment, the UK hospital bed numbers per thousand is towards the lower end of the spectrum in terms of what other nations are actually doing. Next slide, Elle, please. So if we relate this, and I've said I relate this to the nurse population, and again, where available, the figures there are shown for sort of a 20-year spread between the year 2000 and the year 2019. So if we look at what's happened in terms of that, again, we're looking at Switzerland, Norway, Germany, have the highest level of trained nurses per thousand of population. The UK is slightly below the OECD average in terms of the figure right about there of 8.2. Lots of OECD countries increasing the per capita nurses. Don't have an actual figure for what happened between 2000 and 2019 there. But we're looking at around about 8.2 per thousand of population, round about the middle of that particular graph. Next slide, Ellie. When we relate that to the amount of training that's actually taking place within the UK, see the amount of nurse training that's actually taking place. So there are countries who are investing significantly in terms of the amount of nurses in particular that they're actually training. Australia shows there as a significant investor in their nurse training over the last few years. And I think that's been clear because there's been quite a lot of attempts in terms of nations across the UK. I know it's happened in Scotland, but we're looking towards Australia in terms of potentially a source of nurse recruitment across across our country and across the UK as well, because significant investment in training in Australia, high levels of investment across other areas. You see there Canada and the other countries that have been highlighted before: Finland, Germany, Norway. The UK lags behind in terms of nurse training. Obviously, the red bar there. We're looking at a figure of around about 30 per 100,000 in terms of graduates. So certainly behind Australia, which looks to have almost around about 3 to 4 times the size of that, and behind USA. So a lot of graduate, a lot of nurse training, a lot of graduate output in other countries. So significant investment. UK. And of course, ramping up the amount of training that's actually done. But this is not an easy process. This is not a short-term fix in terms of actually increasing the available nurse training space, because it's very dependent on university capacity, physical capacity to actually train it. Also, the ability to actually have supervised placements within an already sort of overloaded system. Pandemic hasn't particularly helped that situation and our ability to do it, although I know a lot of this training has been undertaken virtually in the last few years, or remotely in the last couple of years during the pandemic. Next slide, please. So if we relate that figure to the amount of foreign trained nurses within countries, we'll see that actually the UK starts to loom higher in terms of our the number of foreign trained nurses within the workforce. And this reflects probably our need across the 4 countries to augment our workforce quickly. So we're looking to recruit existing already trained registered nurses into the UK workforce. And that effort has been fairly significant certainly across the last couple of years. It's interesting to see that some of the areas who actually train significant amounts of nurses, particularly if you look there, Australia and New Zealand and Switzerland, who are all high levels of graduate nurses are themselves recruiting and trying to augment the workforce. So there's significant investment across a number of areas in terms of the nursing and probably the broader healthcare workforce. If we look at our approach to nursing as a kind of key indicator of how health services are being developed across the world. So significant investment in Australia, New Zealand, Switzerland, and the UK. You know, a lot of effort in terms of actually augmenting and getting more capacity within our workforce as quickly as possible. Next slide, Ellie. So I said I wasn't going to talk an awful lot about the pandemic because we're going to hear from that in future presentations. But I thought it might be useful to look at the workforce priorities that have clearly emerged in terms of workforce planning from the pandemic. So immediately, as we entered the early stages of the pandemic, there was a significant need to create additional capacity to meet rapidly growing health and care demand as well, because although we're focusing mainly on the kind of NHS element of the workforce, we can't forget that the social care sector has a significant influence on the amount of demand that spills into healthcare as well. So immediate workforce priorities about creating this kind of this idea about surge capacity to meet need. A significant effort put into protecting the existing workforce around about health and well-being, both physical and mental well-being. And Colm and Suzanne are going to talk in a future presentation around about work in terms of particularly mental health well-being of the response in this particular area. Added to that, we have, following the development of a vaccine, a need to create a significant, sizable workforce employed in terms of rolling out the largest vaccination program that this nation has ever seen. And increasingly, there's a future focus around about what we need to do within our workforce and within workforce planning to recover, to get us back to the levels of healthcare activity that we've previously seen. Increasingly, we get rather disturbing figures around about the amount of people waiting for treatment within the health service across the UK. So some figures out there last week, which raised a lot of media attention around about the backlog of services. So we're going to need to workforce plan and develop our workforce around about the large number, the high level of backlog in terms of care that's going to be required. It's going to take us some time to actually meet that need. But we're beginning to look at recovery and what the workforce needs to look like, recovery Although it has to be said that sort of these different variants that keep hitting us on a fairly regular basis now are actually pushing that recovery further and further away. So we need to get out of the COVID pandemic before we actually are able to do this. And as well as recovery, we need to look at the preparedness, what happens in circumstances, prepare our workforce for maybe a similar situation in the future. So next slide, please, Ellie. Okay, I'm not really going to talk a great deal about this because I feel as if Julie will address these. But these are some of the workforce approaches that have been put in place to addressing surge capacity. So I'm not going to, you see there, because I'm pretty sure that Julie will talk about them. I don't want to steal her thunder around about that. So next slide, Ellie. So it may be useful to start thinking in terms of our longer term discussion or discussion later about what the kind of policy responses have been or might be across the four nations, what different circumstances we face. So we have different regional government policies arising from the devolved government arrangements within Scotland, Wales and Northern Ireland and England. So different policies around about healthcare, education and employment. I think it'll be interesting to hear what Pat says around about the developments. So the developments about integrated care systems in England, because within Scotland, and I'm sure within Northern Ireland, not sure in the situation in Wales, we have had for some time the kind of idea of integrated health and social care commissioning. So I'm interested to hear what Pat says around about that and what impact it potentially has within the workforce. We've got the impact of legislation covering sort of working hours, the amount of capacity we can get from our existing workforce without putting them under pressure. Also things like prescribing as well will be interesting to see how the different countries approach that. Regulations, the role of professional counsellors, defining roles and standards and developing new jobs. To what extent has the pandemic changed our views in terms of that? And lastly there, we put the role and remit of employers and management. So determination of pay levels and working patterns. In terms of pay levels, we can see that there's some differentiation between NHS England and I'm conscious of NHS Scotland pay levels, because governments in the different regional governments have the opportunity to affect that. So how does that sit in relation to this idea about cooperation across the UK to actually to improve workforce planning, so we're not competing for the same workforce? So next slide, Ellie. A slight extension, just a slight extension of that last slide in terms of highlighting that workforce governance and workforce planning is going to be at the core of any recovery efforts. We are going to need to do things differently, particularly in terms of workforce planning, if we're going to make any inroads in terms of the backlog that that's going to be needed to be addressed. Maybe back to the kind of first slide I showed there about pandemic responses have exposed challenges in terms of existing barriers to workforce effectiveness. So the things that were done before need to be addressed, and we need to embed the changes that have been observed across the pandemic that are proven to help us in terms of developing workforce and workforce capacity. So we've seen a significant increase in the use of digital and health-enabled technology. That's progressed far faster than it would have otherwise. It was always in the background there in terms of what could be achieved, but the pandemic has almost forced us to deliver health in a different way. We've seen the benefits that can be secured from that. What does it mean for our workforce? How is it going to change the shape of our workforce? There's also been variants and variations, emergency variations in terms of the scope of practice, in terms of what healthcare professionals can actually do. Again, that kind of gives us the opportunity to look at how things might be done in the future. To a certain extent, that extends into the idea of prescriptive authority, what elements of the workforce are able to prescribe. And the other area that we've looked at is whether or not there's a potential to increase the pace of training. It's always remained relatively traditionally delivered in the past few years, but this idea about surge capacity has highlighted maybe a necessity to have to look at the kind of pace of training and how we can increase that to get more qualified staff into the workforce. There's the idea about protecting the workforce and protecting the existing workforce to protect the wider system as well. So next slide. Again, I don't think I'm going to highlight too much of this because I suspect it might be areas that Julie looks at as well. So there's key points in terms of how organisations across the 4 nations have actually looked at responding to workforce need. And the need to get additional workforce capacity. So I think I'm going to leave that. We'll highlight those in terms of the bullet points. You can have a look at those later if you want to. I'm sure Julie is going to look at these particular issues in terms of a Welsh perspective. So we'll move on to the next slide. And a final comment in terms of this section. So back to the OECD. And they highlight that it's a lack of health personnel. So it's a lack of the healthcare workforce that has been a constraint in terms of our ability to react. So we looked at the number of healthcare beds, the number of acute beds across the various OECD nations, but actually it's the availability of workforce that has been the overriding issue in terms of dealing. And the fact that has been so clearly highlighted by the pandemic shows that we're going to need to have a completely different approach to workforce planning in the future. So if we move to the next slide, I thought I'd try and give you a little bit of flavour about, from my perspective, what's been happening in terms of workforce planning in Scotland in the last couple of years. As part of my work at the Scottish Government, we developed what we refer to as the first integrated health and social care workforce plan for Scotland. And you can use the term integrated loosely because to what degree we can clearly analyse the impact of social care provision on the need for health services. We're in the early stages of that at the moment. But what we did was develop a document that actually did start to look at the combined nature of demand for NHS services and cross-referenced it with the demand for social care services and what actually that meant for both elements of these workforces. We're also looking at the development of workload tools from the Health and Care Staffing Act Scotland. We'll talk a little bit about that in a couple of future slides. Maybe thought it might be useful to look at future developments across the system in Scotland, the development of a whole systems approach to workforce modelling, and a national care service, which is in discussion within Scotland at the moment. So move on to the next slide, please. Yeah, so as I've said, the kind of integrated health and social care workforce plan for Scotland was the first attempt to look at the wider health and social care system in a single document. We introduced for the first time the concept of scenario planning. And this was relatively high level in terms of the content of the workforce plan, predicated around about population change and demand for services. So we introduced a number of potentially different scenarios that would actually would assess the need for workforce across various job families. And that led to some significant investment in a number of particular areas out of the workforce plan itself. So managed to use scenario as a first option in terms of developing or augmenting the workforce. The other area that this document particularly looked at was longer term workforce planning cycles, and it might be useful to, again, to use this as a discussion point. So previously within Scotland, there had been a process of annual workforce plans. So the 14 territorial and 8 special boards within Scotland were asked to develop workforce plans on an annual basis. And there was always the sense that that was far too short a period in terms of workforce planning. What you could meaningfully achieve within an annual cycle was limited, and it'd be much more advantageous to look at a kind of coordinated, longer term 3 to 5 year workforce planning cycle. And previously, we've seen the documents within the rest of the UK nations, England in particular, look at much longer, sort of 10 to 15 year workforce planning cycles. So alignment of these workforce planning timeframes might be something that we want to discuss about. The other area that the integrated workforce plan looked at, really for the first time in some considerable time, was augmenting workforce planning as a specialty as well. So there was discussion around about the need to create wider workforce planning capacity within the system, and as well as capacity about capability. So workforce planning as a particular specialty. There are a limited number of workforce planning education courses around the UK, getting even more limited in terms of availability. So if we want in the longer term, if we want workforce planning to function correctly, we need to make sure that there is a cohort of people within the organisation that have the ability to do that. That needs to exist at all levels, not just specialist workforce planners, but also sort of service and line managers, so that they have an understanding of planning the workforce correctly. Now, unfortunately, in a fabulous example of timing, the Integrated Workforce Plan was published in December 2019, probably 1 month before the pandemic hit. So a lot of the aspirations that were outlined within that document for Scotland have actually delayed due to COVID. We'll move on to the next slide, please. Okay, so one of the issues that's happening within Scotland is the introduction of what's referred to as the Health and Care Staffing Scotland Act. This act enshrines the use of workforce planning tools and statutes. So there's an example there. There's 13 workforce planning tools, workforce and workload planning tools, primarily for nursing, that existed. These tools were based on kind of Keith Hurst's models of workload assessment, and had been developed in Scotland across the last decade. So they were available for organisations to use, and they're hyperlinked there. So when you get the copy of the slides, you can click into them if you're particularly interested in the detail of these workforce plans. We move on to the next slide, because that talks about what the obligations are here. So the Health and Care Staffing Act will mean that basically all organisations are legally obliged to use the available workforce tools that are there. Okay. Now, at the moment, this primarily applies to the nursing workforce. There's a duty on NHS boards within Scotland to produce annual reports on the output of their workload tools. So feeding that back to the Scottish Government in terms of what that actually means for their workforce. Too much, too little, what they need, and what that says about workload demand. As part of the Act, the Cabinet Secretary for Health and Social Care in Scotland will have to make a statement to Parliament, to the Scottish Parliament. And I know that there are kind of similar approaches. There's been a Commons committee in England talking about effectively the need to report demand across England. Health and Care Staffing Act applies to all available workload tools, but also extends that because as part of this work, there will be the development of more workload tools for other NHS job families, but also for care home settings as well. So in the future, we will have a tool for modelling the required workforce within social care and particularly care home settings. Can we move on to the next slide, please? Okay. So in terms of what we're looking at in the future in developing workforce planning within Scotland, we've started to extend this idea of scenario planning that was included within the first integrated healthcare plan, and look at a wider whole systems modelling approach. This is kind of almost like I don't know how many of you would have been aware of the kind of systems modelling work that took place in England a few years back. But this kind of idea about linking workforce demand, clinical activity, and financial resource. So looking at these kind of three strands of planning, it's always been the kind of holy grail of making linkages between clinical activity and resource, but not just that, moving it into a more complex environment where we assess the impact of activity in one area on the requirement for workforce in another area. So we're in the foothills of actually saying, okay, well, if we make changes in the clinical model in acute services, what's the downstream effect on community care? Or similarly, if there are changes within the care services workforce, so the social care workforce, what's the upstream effect on demand for clinical activity? So we're beginning to look at that in terms of actually trying to use that for modelling purposes. Last bit that I have here is around about proposals that we have at the moment for the development of a national care service in Scotland. So effectively mirroring the National Health Service. There's a consultation document out at the moment within Scotland that talks about whether or not we need something similar for care services, and proposals that any national care service would have a similar responsibility for workforce planning, and for workforce planning the social care workforce. So that's where our future is lying at.